Hi, everyone, and good day. I think for some of you, it's good evening. For some, it's good afternoon. And I know for some, it's good morning as well. Fantastic to have so many people join us from across the whole country. This, I think, would be close to about the 30th, if not past the 30th mark, in terms of webinars that Pallium has hosted related to COVID. And this is moving beyond COVID now. And today, I think we've got a fantastic webinar with two amazing people who I've known for quite a few years, and I know have done amazing work in this area over the years. So today's topic is advanced care planning and goals of care discussions, and we've got Dr. Leah Steinberg and Dr. Jeff Myers helping us and sharing with us their insights that they've gained over the years and from their clinical experience, their academic work, and also framed it into a fantastic model that we can use. Next, please. So just some housekeeping. Your microphones are muted, but we do invite you to interact and to participate, and please do that through the Q&A function. So on your screen, you should see a Q&A function. Please use that to submit questions. We'd ask you not to use the chat function for questions. It's much easier at this end, and for everyone else if it's done through the Q&A. So please do participate through questions or comments or insights that you may have as we go along. The session is being recorded, and you will be emailed links once, within a few days. You'll be getting links to the session, and the sessions are usually also placed on the COVID resource area or the webinar resource area of Pallium Canada. Just in terms, next please. In terms of declarations of conflict of interest, I'm simply moderating. By the way, I forgot to introduce myself. I'm Dr. Jose Pereira, and I'm Scientific Officer of Pallium Canada. I'm also Professor and Director of the Division of Palliative Care at McMaster University in the Department of Family Medicine. Pallium Canada is a non-profit organization. And over the years, we've been funded largely by contributions from Health Canada. Our presenters today, Dr. Jeff Myers and Dr. Leah Steinberg, have declared that they're clinical advisors for Hospice Palliative Care Ontario, so HPCO. And now let me introduce you to our presenters today. And I think going first is going to be Dr. Jeff Myers. So let me introduce him first. Jeff is an associate professor in the Division of Palliative Care in the Department of Family and Community Medicine at the University of Toronto. And his colleague, who's also in the same division and the same department, is Dr. Leah Steinberg, assistant professor. Both have done enormous amount of work in this area, and I know Leah as well collaborated with her amazing insights on some specific patient populations, including patients with heart disease. So over to both of you. Thank you very much for sharing your insights with us.
Thank you so much, Jose. It's a pleasure to be here and to be with you, whether it's the morning, the evening, or the afternoon. Welcome. Leah and I are very grateful for the invitation and very much forward to what we hope is a discussion and a dialogue. So just to reiterate that we really encourage any sort of questions in the Q&A box, and at any time throughout the presentation, Leah or I will interrupt each other and look forward to it. So what we're hoping by the end of the presentation is to really outline for you similarities, differences in the relationship between advanced care planning and goals of care discussions. We want to be sure that we sort of explore and understand how values can inform decision making. We're going to give you some communication tips and around the processes for both advanced care planning and goals of care discussions. And we're going to explore a framework that really intends to clarify ACP and goals of care discussions in the context of knowledge and skill acquisition and as well implementation. There's so many initiatives across the country, across the world that are involving advanced care planning goals of care discussions that we really felt compelled to try and clarify some of these really sort of confusing topics for many. Just a quick acknowledgement to our colleague, Dr. Nadia Cardona, who's sort of the third in a trio with Leah and I in terms of this work, and then also to Hospice Care Ontario for their great leadership in this area. So as I was saying, there's a great deal of interest in improving experiences and getting advanced care planning and goals of care discussions right. And when I say improving experiences, I really mean care experiences throughout the trajectory of illness, which is what we're going to get into in much greater detail. There's much greater recognition when I compare to 10 years ago, 15 years ago. I've been at this for 25 now as a palliative care clinician. There's such greater recognition that these conversations matter, and that there is a set of skills that are important to go along with them in order to do them well. But the challenge that we're starting to see over the last couple of years is a great variety in the terminology, and that's for clinical settings, educational contexts, and across the literature as well. There's such great variation in how these terms are used. And what this does, in our view, is it creates a lot of obstacles when individuals or teams or institutions or even provinces are trying to apply this information into sort of meaningful projects and initiatives. So as I mentioned before, a framework that is what we're going to be presenting in this first section that really intends to act as a scaffolding for advanced care planning and goals of care discussions. And that's how we're looking at it, as a way to kind of organize all of the terminology and even all of the tools. And again, in support of knowledge and skill acquisition as well as implementation. The way that we're going to introduce this framework to you is using a case, and we're going to introduce you to Joe and his wife, Sandy. So Joe was recently diagnosed with Parkinson's. Sandy is Joe's substitute decision maker. And over the next few years, Joe and Sandy will interact with several clinicians in different settings. And just to give you a sense of this, this is a timeline meant to reflect a number of different care settings, meant to reflect a trajectory over time, or a timeline of a trajectory, and also meant to reflect that many care and treatment decisions will need to be made throughout this journey that Joe and Sandy will be on, as reflected by the D. It really is the decisions in that final part of a journey that is where we're hoping to improve. I think the decision-making process needs to improve along the way with somebody who has serious illness. But in particular, when we're talking about measuring the effectiveness of advanced care planning goals of care discussion, we're looking at sort of goal concordant care is often what's cited, and in particular in that final stage. When you look at the evidence around many different kinds of serious illness, and so Parkinson's being one example, heart failure, metastatic cancer, COPD, chronic kidney disease, dementia, frailty, neurodegenerative diseases as well, all of these serious illnesses, when you look at the evidence for what people understand about their illness, it's quite poor and jarring, actually. So there's a very good chance that both Joe and Sandy won't understand what it means to have a serious illness, what it means to have Parkinson's, and won't be prepared for decision making. So when I say what it means to have a serious illness, what I mean is won't understand the incurable and progressive nature of Parkinson's. And you can see over a period of time how much of an impact that would have, particularly in that last phase. And so if we're looking to improve care and improve experiences, as teams, we really need to be sure that both Joe and Sandy understand Joe's illness and prepared for decision making. Okay. So coming back to our timeline then, some examples of decisions that might need to be made regardless of where on the trajectory that Joe is. You may find a lung lesion incidentally on chest x-ray. Should Joe have that biopsied? He develops AFib, but is at high risk for a fall. Is anticoagulation something appropriate to begin? As Joe function worsens, Sandy's beginning to wonder if long-term care would better meet his care needs. So these are the kinds of decisions that need to be made, and what we're proposing that we think of goals of care discussions as the framework or as the entry point into decision making. When there is a care decision that needs to be made, hopefully a values-based goals of care discussion will be what occurs that ensures illness is understood, ensures what to expect moving forward is understood, and ensures that a person's goals are aligned with the available approaches or options in terms of the care or treatment that's being offered. The next most important point of a decision-making process, or element of a decision-making process, then would be consent for treatment or care. And sort of briefly, what that looks like is the risks, benefits, and alternatives being fully explored by the clinician who's proposing the treatment or care. Okay. So if we think about this entire illness journey, though, that's just for decisions. You know, we've got a sort of a sense of what to do when there are decisions to be made. What will help prepare Joe and Sandy for in between these decisions? What will help prepare them for decision making in the future? And this is where advanced care planning comes in. Advanced care planning, then, as we think of it, they're preparatory conversations in between decisions, and the sort of outcomes or intents of these conversations are to confirm a person's substitute decision maker, ensure that the illness that the person has is understood by both the patient and their SDM, and sets decision-making up in such a way that values-based decision-making can occur in the future. And the way to do that is by exploring values in the context of advanced care planning. Okay, so the way that we've kind of put these together then is in this pyramid, and acknowledgement to Nova Scotia Health, who first sort of conceptualized the pyramid, and we sort of modified it. And kind of just another way to think about this in terms of the outcomes is that for advanced care planning, substitute decision maker is identified, the patient and SDM are prepared for decision making. Okay. For goals of care discussions, again, the illness is understood and decisions are guided by values and goals of the patients. And then for consent, the risks and benefits and alternatives are fully explored by the clinician who's proposing the treatment or care. So what do we mean by values-based decision-making? Okay, so we're going to do a quick thought experiment, and we're not going to do this as a poll. And so I just want you to think as I go through this scenario, but I am asking you to think for yourself, okay? If you suffer a life-threatening injury and are offered a surgery that could save your life, the surgery, however, has an 80% chance of paralysis for both upper and lower limbs. And the question that I would pose to you is, would you have the surgery? Okay, I can give you a few seconds to reflect. And the next, what would you do? Is you have a debilitating motor condition and you're offered a medication that allows most patients to function independently. However, most patients also experience a 30% reduction in cognitive function. Would you take the medication? Yes or no? So usually when we do this, there's a 60-40 split, 70-30, sometimes 50-50 for both questions, which is always an interesting sort of finding in that obviously there's no right or wrong, but there's a process that a person has, that healthcare clinicians or people in the healthcare field, healthcare system, there's a process that we go through when we're presented with something like this. And I just want you to reflect for a second on how you arrived at each of these two decisions. What went through your mind? And what I would propose is that as you read the words and the word paralysis, or the words 30% reduction in cognition come up, that creates an image, conjures up an image in your mind of what that looks like. You know what that looks like. What you then do is probably subconsciously, is you compare that to an image of life that you would consider acceptable or unacceptable, tolerable or intolerable. And you compare these two images, and that's really how you make a decision. If it is unacceptable to you to risk loss of cognition at 30%, then you're not going to take that medication. If that's an acceptable to you so that you can maintain physical function with the debilitating condition, then you would say yes. So you're comparing these two images, one of what the future looks like because you know what these words mean, and the other of what you consider acceptable or tolerable. That's what patients do as well. So when we're asking patients to make decisions, patients or their SDMs, they're not envisioning their future in terms of the FEV1 or percent tumor burden or kidney function or wanting dialysis or not. They think about the outcomes of treatments. They're looking to imagine what life will look like and how it will be affected by illness and treatments. So essentially, that first group of images around for paralysis and 30% reduction in cognition, it's really important that we see our role as painting these pictures for patients and their families, these two pictures, and help to clarify. So there are two sources. How I think about these is that there's two streams of information. There's information and evidence about illness, about the disease, about treatments. In the scenario that we gave you, that was the examples were paralysis and the cognitive reduction. And then there's the other information stream, which is about the person, what's important to them, why it's important. And how that manifested in your decision was whether or not it was acceptable or tolerable to have these states. Both sources of these information are necessary for decisions to be effective, okay? So bringing it back to advanced care planning and goals of care discussions, when we're having advanced care planning conversations with a healthy, capable person, there isn't going to be an illness context. So really the information that we need to get from them at that time is about them, what's important to them, why it's important, what's the image of life that would be considered unacceptable or intolerable for you. If a person has a serious illness, we're still can have advanced care planning conversations, and the focus for these can be on the illness and the disease, what the incurable and progressive nature, what to expect moving forward. So you can see that there's a lot of work that can be done before decisions actually need to be made. When it is time for a decision, goals of care discussions and consent really are bringing these two information streams together. Okay. So a final way to kind of think about this framework is really asking yourself the question as a clinician, if for the clinicians that are watching or that are participating, is a treatment or care decision needed? Because if it's not, then it will either be advanced care planning for a healthy, capable person, or it might be advanced care. There might be a serious illness context. And if a person does have a serious illness, then it would be advanced care planning for that person who has a serious illness. If their serious illness is so advanced they no longer have capacity, then the preparatory conversation that we have with people would primarily be with this substitute decision maker to really prepare them for decision making in the future. And you can see here that this is where illness understanding really becomes a priority. If there is a treatment or care decision necessary, however, that's when the whole stream of goals of care discussions, consent, and then initiation or not of treatment would move forward. So I actually didn't, and Leah, I'm going to transition to you in the next slide. And so I'm curious to see your expression, but I wanted to bring it back to Joe and Sandy and sort of just make the point here that advanced care planning and goals of care discussions are setting agnostic, right? So there's not a specific conversation type that only applies to one setting. I'll give you an example. In the acute care setting, if somebody's admitted for heart failure exacerbation, at the beginning of their admission, they may not have the ability, it is going to be goals of care discussions because there'll be decisions to be made. But nearing the end of a person's admission, they have capacity, it's a perfect opportunity actually before they go home to have an advanced care planning conversation because you've got this immediate context that they've just gone through. If there's no decisions to be made, then really ACP can happen in the hospital. And conversely, advanced care planning can certainly happen in primary care offices, but so can goals of care discussions as well. They're setting agnostic, and they really do span the course of a trajectory of a person's illness. And with that, I will turn it over to Leah.
Thank you, Jeff. That's great. Let me just see if I can forward the slides, which right now I can't.
Try again. I just gave you the remote.
There we go. Great.
Oh, yeah. You mind doing these two slides, Leah? Sure. Yeah.
I don't mind. So I'll just carry on from this. Can you go back?
I'll take it. You can take it. Yeah.
Thanks. Great. So earlier on in the session, Jeff mentioned how one of the things that's driven us to really try to think about an overall framework is that there are so many now different tools and guides and communication programs that speak to the work of advanced care planning, and they're all good. The problem is, that they all use sort of different language, and they come up with sort of different outcomes, and there's different priorities put on them, and I think it can be a little bit confusing for the clinician to train in one of them and then it not be clear sort of what outcome they're going for. So that's the intention of the framework, was to help people understand when they take these workshops and learn these skills, what it is that they're doing. The same applies for goals of care conversations. There are fewer frameworks, but there's multiple of them. And I'll just take the pause here to sort of make sure that people really realize that the other reason that we really want to talk about this is that there's a growing sense that when somebody talks about, at least in my hospital, a goals of care discussion, people think that it's the same as a code status conversation. And I want to just make sure that I say that out loud at least once, that that's not what we're talking about, that somebody's decisions around code status or recommendations around code status may be the result of a goals of care discussion, but it isn't the goals of care discussion. And so I think that we have to start to really be clear with the language. So for the next section, what we're going to talk about is, Jeff, can you go back a slide? It's a little glitchy. Thanks. Is this guide, this framework for having conversations. The lovely thing about when Jeff and I started doing this work together is we realized that although the outcomes will differ between an advanced care planning conversation and a goals of care conversation, the actual structure of the conversation and the skills needed are extremely similar. And so we were able to kind of put this framework together that's really a hybrid of a lot of the other workshops that I showed in the previous slide. They're all good workshops. They all focus on slightly different parts of the conversation. And so what we've done is based on that work and work done years ago even, especially around Breaking Bad News work, come together with this hybrid that tries to address the major components of these conversations. What I'm going to do is talk about the principles, and then we're going to go through in the time that I have to pick out a couple of points about each of these steps so that there's some tools and communication pearls that you can start to use right away. Really, the process of learning how to do this takes time. It's often skill development that you build over time. You may take a workshop or training to actually be able to practice this, but even then, it is still something that's a procedure that takes practice. So I want to make sure that people realize that. Okay, I'm just trying to forward the slide. There we go. So before we get into the details, I just want to address a couple of overarching principles to these conversations. The first one is that to do these conversations well, and I'll try not to be too soapboxy, as my learners sometimes say that I am, to do these conversations well, we have to really realize that what we're doing, we have the medical expertise already. We know the different treatments, but what we're really doing to do this well is we're learning about the patient, the person, their SDM, really the world as they see it. And so we can't know the outcome of that conversation, of a goals of care conversation specifically. We may have ideas about what treatments we think would be best, but these are value sensitive discussions, and the decision has to be something that you arrive at with the patient. If you go in with a really strong preconceived notion of where you think this should go, you actually won't be open to hearing the world as the patient sees it. And if you do hear the world as the patient sees it, you may actually realize that treatment decisions should look different than what you had thought. You'll be open to compromises and to finding actually new solutions together. So I find the hardest thing that people do, or the thing that I coach people to do a lot, is to just go in with a really open mind and be really flexible to listen to what patients are telling you. The second principle is that,
sorry, Leah, I'm going to take control because there's just so I can get the Q&A. because I
Excellent.
can't. So I'll
Okay.
just tell me when you want to advance the slide, okay?
Perfect. Thanks. Is that when I teach this to non-physicians, there's really not a lot of clarity I find in what non-physicians or non-NPs can do. And the truth is that these are conversations that all healthcare providers can do. Even in a goals of care conversation, a lot of people will say, well, it's not in my scope of practice to, give a prognosis or give a diagnosis. But the fact is, as I'm trying to say from the first point, a lot of this is much more about understanding the person and understanding what their worries and fears and goals are. And that is an enormously important contribution to this conversation. So I just want to really stress that this is a team effort. These conversations are also obviously iterative. I think that's pretty clear. You may go partway down a conversation and realize that somebody's illness understanding is really different than what you thought. And that you may have to stop, go get some more information. You may learn something from them that makes you realize that you don't have the understanding that you thought you did. You may realize that the information they needed was much more, and it's not a good time to carry on because they need time to process the information. So it's okay to stop and come back later, obviously, if there's time. We'll talk a little bit later about if there's not much time. Think of these conversations as more guidance and coaching than trying to talk somebody into what you think is the right decision. You can only move somebody along, first of all, if you're starting where they're at, and if you're understanding how to move them step by step. And lastly, and I feel like every time I say one of the principles, I'm going to say most important, but I'm trying to not do that. Equally important is that these conversations should be emotional. They're going to be, and if they're not, then that's sort of unusual. And unfortunately, healthcare practitioners aren't really trained well to sit with emotions and really manage the time through the emotional reaction. And it's really essential because what I think we miss in these conversations is that when the person is having an emotional reaction to news or information, that's them actually letting it sink in and letting it move them. And when we stop that process from happening, I think that's what often leads to the phenomena that they didn't actually understand where this is going, or they didn't hear me, or they just don't get it, is that we haven't actually given them the opportunity to process the information. So that's a really important skill to develop. Next slide, please. All right. So
sorry.
It's okay.
Sorry.
It's okay.
There you go.
So what we're going to do now is go one by one and just highlight a couple of points, because this we want to leave time for questions as well. So next slide. Oops. So I'll just start while Jeff gets back to the previous slide. Thank you.
Sorry. Yeah.
Perfect. So for both conversations, it's really important to start by preparing yourself. And again, this could take 2 hours to go through, but I'm just going to point out some tidbits for it. It's important that you do know, especially if you're having a goals of care conversation, kind of what the medical information is, if you're going to be the one who's giving the information. Most important, and this is a little bit like what I talked about earlier, is to leave your agenda aside when you go into this meeting. And you want to take a supportive attitude. Not a lot of people sort of dread these conversations, but if you actually see this as the way to bring your patient's values, illness understanding into the decision, it's actually a much more powerful tool. I want to point out the one interesting difference that I find between advanced care planning and goals of care conversations when we're thinking about preparing and getting into the conversation. Advanced care planning conversations are really by definition proactive. There's nothing that's driving the clinician in that moment or the patient in that moment to engage in this conversation. So it's actually a break from our normal clinical procedures. So if you're taking care of somebody with heart failure, say you're a cardiologist, and you have a really set way of managing your clinic, they go and get their ECG, maybe they get some blood work, they come in, you review the results, you find out how their symptoms are, you adjust their medications. There's a real continuous stream of moving people through a clinic, where if you have to then think about doing advanced care planning, you actually have to change what you are doing to bring up a different kind of a conversation. And so it's really important that as you're working to include this in your practice, that you have some ways of breaking kind of the flow of your clinic, so that you can step back and bring in a conversation. Whereas in a goals of care conversation, there's a treatment decision right in front of you. There's something much more pending. And that is something that clinicians are much more comfortable with, because you're actually reacting to something. And so I think that's a fundamental difference that makes it something that you have to think about a little bit more. Next slide. So just a quick example, and there's lots of websites with phrases that help you into these conversations, but just an example for an advanced care planning conversation, you have to find a way to kind of step back a little bit from the day-to-day, clinic work. So you might say, Joe, you've had a few changes in your health over the last, whatever, days, weeks, months, and we may have some decisions coming up in the future, or something that works in your language. Many people find it helpful to talk about what's going on with their health and to start to get prepared for a time when we may have decisions to make. This is called advanced care planning. Have you ever heard of that? So I really encourage people to, in their own clinical context, come up with phrases that will help them step back from the everyday monitoring the blood work, checking the medications, so that they can start to introduce these conversations. Next slide, please, Jeff.
And just to let people know that I do see the questions in the Q&A, and I will interrupt Leah if it's got to do with the content that she's talking about in the moment. But if not, we'll for sure come to the questions when we get to the Q&A, okay?
Great. Right. So the next step, once you're prepared and you've introduced the conversation, is to really explore where somebody is starting from. What's their understanding of their illness? And I see a lot of people doing this now, but unfortunately, they're not actually taking enough time to explore the illness understanding. When you first ask somebody, tell me what the doctors have told you, or tell me what you understand, we have to realize that patients are in a very scary, vulnerable position, and they're not going to share everything for the most part when you first ask them. They're not sure, do you really want to hear this? Are you safe? Are you going to judge what they say? And so I find that it's really important to ask for their illness understanding, but then really take a posture of letting them tell you and encouraging them to tell you more. Because a lot of times people will start, they'll say, well, I know that my heart's weak. That's what they told me. And then what I find, a lot of people will say, okay, well, let me tell you what's going on. And so you're making your job harder. What I would really recommend is that you wait, and you can ask and use communication skills to let people tell you more. Because most of the time, I like to go in, I can't say most of the time because I don't have that kind of data, but I actually believe that if you assume that people know more than they're initially telling you, you'll actually uncover that they do know a lot more. And the wonderful thing about that is it's a lot easier and it's a lot more compassionate to use the words that you hear somebody using and use them in that conversation. So really understanding how they talk about their kidneys or how they talk about their cancer, and using that language can really both build rapport and help you get more information from them. So what I like to do is teach 3 different skills that encourage people to talk. Because as I'm doing now, we're very good at talking to people. We're not so good at sitting back and letting them talk. So the first is asking open-ended questions. These are all things you guys have all heard about, I'm sure. We just don't get to practice them very often. So I would really encourage you guys to practice these. You practice them on your family or on friends. So instead of saying, did the doctor tell you what was wrong? So the person can say, yep, Okay, so that gives you no information about their illness understanding. You can say, can you tell me what the doctor actually said about what's going on with your heart? And that way you'll actually start to uncover what they learn. So what they know. So that's the first thing. The second is using what are called reflections. And anybody who's trained in sort of motivational interviewing or other kinds of counseling will know these well. And a reflection can be actually lots of things, but a simple reflection is in a curious, open tone, repeat the last thing that somebody said. Somebody said? That's right. Just repeat the last thing they said, because it's really, so I just did a little reflection there. It's really, it's an invitation to the person to tell you more. And it might seem really like you're kind of acting or a little bit artificial when you first try it, but it's very powerful. And one of the things I love about reflections is you don't actually have to think of something smart to say, right? You don't have to think of a really great open-ended question, or you don't have to think of something that, a great therapist would say that would like push the conversation along. You just have to listen to the last word and repeat it. So that would be, that's a really good skill, but you do have to practice it again. And then the last, which I'm just speaking up a little bit louder because I just saw that maybe I'm cutting out. So hopefully this will be better, is practicing and using silence. Anytime that you want somebody to tell you more and they're not looking right at you for an answer or looking right at you to keep the conversation going, just wait and just count. Just like that. And they're almost always going to fill in more information for you. So these are very powerful skills. I'm hoping, let me just pause for a second. Am I cutting out less now?
I think not for me, Leah.
Not for you. Okay.
So
okay.
yeah, if folks let us know if there's a problem, yeah.
Okay. The thing that you're doing here, so there's a lot of different skills or things that I'm listening for when somebody's talking. I'm just, I'm not just sort of letting them talk for the sake of talking. I'm actually listening for cues. I'm listening for things that give me a way to ask more about something specific, but I can use their words to ask it. So if somebody says something like a kind of throwaway, or just like not throwaway, but they say something like, yeah, I just wasn't sure what happened last time, right? Just something like that. It lets you say, oh, tell me more. What do you mean happened last time? Or what were you concerned about? So all of the times, this is called active listening, which I know we all know about, but the point is that you're really listening to hear those cues that invite you in to get more information. So that's the purpose of this. Okay, thanks. Next slide. Again, I just want to keep it reiterating that this work can be done by many clinicians, nurses at the bedside, social workers, trying to understand where your patient is at in their illness understanding is very, very powerful work. And even if you aren't feeling that it's in your scope to tell people information, you could try this. Next slide. You might be able to say something like, it seems you're not really sure what might be happening with your illness as you go forward into the future. Is that right? Would it be helpful if I ask someone to give you more information? So that identifying that they need more information and supporting them to get that more information is almost everything in having these conversations. So I just really want to encourage you to do that, to try this. Next slide. So when you feel like you have gathered as much information about their illness understanding as you need to move forward, the next step, and this also takes a lot of skill, is to give information about somebody's illness. And the thing about this is there's only a couple of fundamental skills that I want to cover. Next slide. There's a couple, so if you're doing, I think of this a little bit more in the advanced care planning world, but even in goals of care, you need to be able to explain the trajectories of the common chronic progressive illnesses. So I would ask you guys to reflect, how many of you have a way that in English you use to help somebody see the whole trajectory of their illness in a supportive way that gives them the tools and the knowledge to feel more prepared. Next slide. So use visuals, and I'm not going to get into it here, but what I'll do anyway. Next slide. So, for example, if you're talking with somebody who has dementia or their family, the first thing that I would recommend, or with anytime you're giving information, is to ask permission to give information. So anytime you're doing this, I always start by saying, thank you for telling me what you know about dementia. I have some more information, and I'm wondering if it would be okay if I gave you that more information. So why, I want you guys to just think for a minute, why, because we can't really be that interactive. Why is it important to start by asking for permission to give information? It seems a little bit funny, right? I'm just going to pause there and let that question in. The reason that I ask, yes, somebody wrote respectful, absolutely. So first of all, it lets somebody say no. It wouldn't be okay. This isn't when I'm prepared to hear about it. And so that's really great to know. It gives them some control over hearing hard information. Sometimes I even might say, you know what, I have some information that might be hard to hear. I'm wondering, would it be okay if we talked about that now? And that lets them have all the control that they need to say, you know what, that's not how I go. I like to hear information when I need it. I don't need it now. And that you haven't injured a rapport or relationship. But there's another important reason, which is that, again, it gets back to people being emotionally involved in these conversations. They're scared, maybe they're angry, maybe they're upset or worried, and they're not really using their cognition as much as their emotional part of their brain. And so when you prepare them for information, for listening to information, you're actually helping them use their frontal lobe a little bit more. You're kind of giving their brain a little bit of a warning to say, okay, it's time for you to do some listening here. And it sort of settles them into a place where they're probably listening better, as opposed to if you just launch into the information, you're probably just speaking to a lot of emotion, and that they're not ready to hear it. So we don't have time today to sort of talk about how to talk about the trajectories of chronic diseases. I've heard some beautiful work by some of the people in the Alzheimer's Society as they can teach about dementia, and they start by saying things like, you know, Alzheimer's dementia has typically about 3 phases. And then they go on to explain, in the first phase, this is what you can expect to see. And in the second phase, this is what you can expect. Now, the other communication skill here is to give this information slowly, okay, with good pauses in between. So I might say, we commonly see 3 phases in dementia. And then pause, because again, you're giving people back the control to say, okay, actually, you know what, I didn't really want to know this. Or for them to just catch up to your words. And then you'd say, let me tell you about the first phase. This is what we typically see. And then pause and let them respond so that you're actually in a conversation, not just a lecture. If you're dealing with diseases like heart failure, COPD, even liver disease to some extent, there's a typical trajectory that's the up and down trajectory of those illnesses. And I often will actually sit down with somebody and draw the trajectory for them. And you can even personalize it and say, you know, do you remember 5 years ago you came into hospital and you were in heart failure, and remember it was hard to breathe. And you were down here and we were able to put in a pacemaker, give you some of the water pills or the medicine to get the fluid off your chest. And you got a lot better. And then you were well for, 3 or 4 years. And then you remember you came back into hospital. And so you draw the up and down. And that really helps people see that, first of all, this is the normal expected course of heart failure. And so I usually reassure them that this is really typical and there's nothing you're doing wrong. And then once you've drawn the trajectory, you can start to help them see where they are. Are you near the end of the trajectory? And so usually I'll say something like, unfortunately, as the disease progresses, we're not able, the medications don't help us get you back up that curve again. And at some point we do run out of options to make your heart feel better again, to make you feel better and able to get back home. And that may be all that they need to hear. A lot of people will then say to me, well, that's the end of life then, right? So again, you can tell them that that's exactly right. That's the common pattern for most people with heart failure. Now, here's the opportunity. You get to tell them they're right. So if you help them tell you, then you can give them feedback that says, that's exactly right. You've understood me really well. And I'm worried that you may be closer to that point than more the beginning. So I'd like to use visuals, and I like to be able to, in English, really explain things to people. Uh-oh, I'm over time.
Leah, if you're that's okay. If you're in this giving information phase and you're sensing hesitance, is it likely that a person is not wanting or not ready to hear the information?
Yeah, so I think that's a great question. I think that is something that you don't know until you've explored it a little bit. I think that sometimes people, that's why it's also a really good thing to say, I have some more information, would it be okay? Because sometimes people will say, well, I don't need more information, I need, and you'll tell that they're actually having an emotional reaction. And so it's a bit of an emotional gap. And so that's a lot of the reason that I sort of offer some information and see what the response to the offer is. Because if the response is one of emotion, they're not ready for information.
But I think the point in that, and just then I'll move on, is that if you're sensing hesitance or reluctance, there may actually be an important emotional gap to address, rather than saying, okay, if you're not ready, that's okay, we'll catch you next time, and moving on. It might actually be worth a few minutes to explore
exactly
that.
Exactly.
Yeah.
So I think it's almost 10 to 4. Do you want? So
why don't you finish up these last couple of slides, and then we can switch over
and
to
we'll
questions.
Get to questions.
There's some
Okay.
great ones.
So the next step is to explore and so their goals and values. And so I usually like to say to somebody, I think that now that you have more information and you have a better idea of what's happening, tell me what would be most important to you, or what are you most worried about? There's lots of ways to get at these values and goals and worries and fears. Next slide. So let's just go through these because you'll have the slides.
Okay, sure.
Yeah, so these are just examples of how things can come through. Next slide. So just quickly here, I want to touch on this. Some people really worry that if I ask somebody what they want, what if they want something that I can't do, that's not medically achievable? And I just want to reinforce that again, it's better to know that and to acknowledge it and explore it. Because if somebody is listening to you making suggestions, but actually they're wanting something else than what your suggestions are heading towards, it's not going to make any sense to them. So there's a beautiful statement here that you can do called the I wish statement. And so if somebody says, it's really important for me to get back to work, but that's really not medically achievable, using an I wish statement shows the person that you share the same goals as they do. It's just not possible. So you might say, I really wish, Joe, that I had the right treatments or had any treatments that would be able to make you stronger and get back to work. And then you leave that there so that you're showing him that you actually want what he wants. It's just not possible. Oftentimes we just avoid that, and it just makes people are confused. Well, do you actually want this for me, or are you not doing it because I'm too old, or I'm, they fill in all kinds of blanks. Okay, next slide. So that's the quick, actually the last stage is to recommend. And so at the end of a conversation, and again, it may be many conversations in, you're in a position to make a recommendation. And if it's a goals of care discussion, your recommendation may sound something like, given everything we've talked about and what I understand about what you're hoping for, can I make a suggestion that we do X, Y, and Z? And if it's advanced care planning, the recommendation may be to come back and follow up with your substitute decision makers so that they have the same information, because they're the ones that will really need that in the future. Next slide. And lastly, there are lots of resources for documenting these conversations. And since this is a Canada-wide audience, different provinces have different forms. And so we wanted to just make you aware that there are different resources available. Thank you.
Okay, so a couple of questions, Leah. The first one, a great reminder actually around I wish, I worry, I wonder, as a continuation of the I wish statements. So just wanted to point that out. Jose, are you okay if I work my way through a few of these questions?
Please do. Fantastic. They're fantastic questions and comments. So
there are. So Leah, a couple of questions actually address sort of prognostic information and either a lack of concrete information, a lack of sort of guidelines, especially for frail populations, or more specifically in the context of cancers, if there hasn't been the participation of the oncologist. So how can we sort of navigate when we're not feeling confident about prognostic information, or maybe not getting the information that we think we might be from our colleagues?
That's a really good question. There's no easy answer to that. The truth is, it is a team activity. And if somebody, so I am very quick to call an oncologist and try to get information from that oncologist to help them. I actually sometimes feel like we need to support the oncologist as well in being able to answer patients' questions. Sometimes you advocate right in the time. So I might, if I know somebody wants information, I might say, I might have a meeting. I try to go when the oncologists are meeting with the patients, which I'm in a very privileged position to be able to do. And I might say, Mr. Smith, I'm wondering, would it be helpful if you knew exactly what the chemotherapy was working towards? So sometimes you have to really be an advocate for your patient to get that information. That's a really tough thing. But I would say, you're an advocate and you're helping them get the information. And so I would call sometimes with really complex patients who have 3 or 4 specialists, what you really need to do is get everybody together so that the worst thing we can do is give people mixed messages. So I would say, do the best you can to find the information and package it and get it together, so that everybody's on the same page. It's not the answer people want, believe me. It's not easy.
So I'll address the next one, which is, does advanced care planning have to be done in the format of written instructions? And I would say that no. The short answer to that is no. Each province does have different legislative and jurisdictional sort of requirements or flexibilities around advanced care planning. There's not a requirement for written instructions per se. And in fact, I think in terms of the effectiveness of written instructions, we worry that people might actually think that they are more beneficial than they are. Most important thing is to make sure that your substitute decision maker is adequately understands illness and understands what's important to you moving forward in the context of your illness. Right, so Leah, next question is a good one around practical tips on how you transition from symptom management to advanced care planning, tips on how to respond to patients who say, I want to focus on positive right now. I'm not really ready to talk about the future. Any tips?
Yeah, go with them. That's okay. When people say that, they're giving you a posture or a stance. They're telling you something they're scared, like they felt a little bit threatened. So usually what I would say is that's great to know about you. Tell me more about what being positive means to you. Just tell me more about that. Just stay there and explore it. Because they're basically telling you, I'm scared, and acknowledge that and listen more. And you know what, over time, sometimes another quick little pearl is I'll say something like, I totally hear that. And let's talk about what positive means. And then what I might say is, if there's ever a time you feel safe or feel like you want to have a look at what might happen if we weren't so positive, I'm really comfortable looking at that. And so just let me know. So I think of it as a little like the sex ed talk, which is like, you want your person to know that they can come to you if they have questions. So sometimes you push a little more. Sometimes I say, can I tell you why I'm asking to do this? But you kind of have to depend on the rapport you have. But I would say the first answer is just stay right there and explore it. It's great that they're talking to you.
time for a couple more, I think, Leah. Interesting questions around whether or not any of the tools or guidelines actually consider cultural or spiritual values of a patient. And similar to that, if we've found resistance to having these conversations in different cultural contexts.
So yeah, there is a growing literature around incorporating different cultural belief systems. There's Indigenous work now being done on advanced care planning. So you just have to look for it. I don't have a sort of a handy resource right now, but we can definitely put that together for the group. What I'm always amazed by is that there's still more intercultural variability than intracultural variability. So every time, you think that there's going to be like, so I tend to find that there's resistance amongst all kinds of people in all kinds of different cultures, and it's not just the culture. There's a lot about coping style and ways of managing fear and distress. So
and maybe one more, if there's time, Jose, for one more, because I think that's an important one, is just sort of when a couple of questions that are around the theme of goals being unrealistic, Leah, and in particular in long-term care facilities, if families are requesting for a patient to be have a full code status, or when there's an emotional gap, really, how do we actually, and so the patient remains CPR, how do we address goals that are unrealistic?
Wow, that's kind of a big question for the last one. I think we have to, first of all, really see where we're coming from. A lot of the time we're putting our own sense of what we would want or what we would want for our loved one. And instead of being open and really exploring what is it that is driving that request, and understanding underneath that request, forget the request. We get very stuck on, he shouldn't have, you want, and you know what? It's kind of not, we shouldn't own that. It just causes your own moral distress. Just ask the questions to understand where they're coming from. And oftentimes you learn that there's actually very good reasons that they're asking for what they're asking. And if you take their stance as the end of the story, then you lose a great opportunity to learn, to create solutions. I'll stop there.
That's the perfect response. And Jose, I'll turn it to you.
Fantastic. Leah, Jeff, that is absolutely fantastic. I was just riveted here. It's a topic where sometimes we think, oh, we've heard it so often, and you've just, I think, opened up doors and windows that I didn't even knew existed, and different ways of looking at it. The imagery from the beginning. So I learned an enormous amount, and I think by the activity on the Q&A and even on the chat, you can see that this was really, really good and really, really important. So with that, I think we will, having thanked both of you for your time, for the generosity of sharing with us not only your time, but your insights as well, and in such a wonderfully eloquent and practical way. Thank you very much. And to everyone who's joined us, we were over, I think, 315 or 320 people at one point. Thank you, and we look forward to seeing many of you, if not all of you, again in future workshops. And given the popularity of this one, I won't be surprised if we may need to repeat another one in a few months' time, perhaps. So thanks, everyone. And as my colleague Denise Marshall says, stay negative, but stay positive.
That's great.
Bye, everyone.
Thanks all.
Okay.
Bye.
Bye-bye.